Simple. Goal is extraction, identify life threats, get them triaged, and get them out. And that's, we want to make this as simple as possible. I don't know why everybody's trying to make this complicated and trying to create this perfect format. You know what the perfect format? Getting the patient to the hospital. That's the perfect format.
Welcome back to the World Extreme Medicine podcast with myself, Eoin Walker. In this episode, I'm speaking with Gregg Brady on pre-hospital triage. So what I wanted to do is really have a chat with Gregg about the evolution and utility of modern day triage and how it's evolved over time. So what I wanted to do is look at some of the incidents that Gregg has dealt with in the past, and indeed look at some of the prevalence of active shooter incidents, extreme violence and or terrorist incidents, barricade situations, and other acts of aggressive behaviour, which Gregg has both interfaced with and indeed dealt with. So some of these challenges and indeed responses test the capabilities of both first responders and indeed mass casualty care plans. So Gregg works for the FDNY, so Fire Department New York, and has the role, and indeed in the past has been a primary response to mass casualty incidents across New York City. So New York continues to be a potential target for domestic and international terrorism. So Captain Gregg Brady has spearheaded the innovative approach to FDNY Warm Zone Triage to quickly address severely injured patients and instill a semblance of organization in the environment which is possibly under threat. So Gregg currently works as Deputy Chief for FDNY, but started out his career in 2000 as an EMT at the age of 19 and became a paramedic in 2002. So FDNY trains in bilateral firefighting and paramedicine. So in 2004, he became a paramedic in the city of Kissimmee Fire Department. Gregg became a tactical medic after that and worked for their police department, their SWAT team, operating as tactical medic for 3 years during that process, and then began teaching tactical medicine as a result. So Gregg has also been deployed overseas in multiple deployments to high threat situations and to orchestrate security for diplomats in various locations. So in 2011, Gregg came back to FDNY, Fire Department New York, and in 2014 was promoted to the rank of lieutenant and started to work with both the hazmat team and indeed progressed to the deputy chief. Welcome to the podcast, Gregg.
Thank you for having me. I appreciate it.
It's great to have you on, Gregg. What we're going to do is a mini series on triage and just look at the different types of triage which are both effective and have iterated over time. And I just wondered if we could start by looking at a working definition of warm zone triage and how it might be different to other tools out there.
That's a good question. As you can see, the development or the use of triage, throughout the world has more or less been fixated on start triage and focused there. And then as the development of the active shooter or aggressive deadly behavior assignments came in, it was quickly realized that with operating in haste and in those types of environments that a lot of gaps were noticed with using start triage. So, the definition of our work in triage is for warm zone would be the FDNY's Rescue Task Force utilizes this triage system while operating under force protection within a warm zone environment to quickly identify our most critical patients and have them extracted in a timely fashion. Again, it's to identify the most critically injured victims and extract them as quickly as possible.
So you said, I fundamentally agree with that about the rapidity of triage, and it has to, in essence, I think, Gregg, to your previous podcast, is it has to be simple because if it's not simple and it is complex, it slows down the whole process. But could you maybe speak to warm zone triage in its simplicity and its application as a tool which is useful to the clinician in the warm zone?
So we really got down to when we started developing our program, we really got down to the basics and pretty much what's our foundation? What are we really trying to accomplish here? And we realized very quickly it's about extraction of victims, where before we would have been outside, never to operate in that environment, or you'd have tactical medics that are going in with their main responsibility to be to their team and mission. The Rescue Task Force was developed to try and get to these victims, get hands on them in a warm zone environment from Columbine, and where these people had survivable injuries where we wouldn't got to them before in the past. So again, realize our foundation and really what we're trying to accomplish here was extraction. It's extractions of those victims and quickly identifying them. Understanding that we had to make it as simple as possible and get to those victims that more or less need to get to the hospital as fast as possible. Not those victims that are going to inundate us as we get there, but that where they don't have the ability to extract themselves, that we'll be able to get in there, identify whether or not they're alive first, right? So we want to take, that quick assessment to make sure that they're alive, that they're a viable candidate. And two, one that has survivable injuries that we need to extract as quickly as possible.
So looking at the differentiation between tools, as you mentioned, such as Start Triage, could you maybe speak to the main differentiators for listeners so that they can sort of understand the algorithmic flow of Warm Zone Triage? Yeah,
so I mean, let's first start off with Start Triage, right? So the number one word in that is simple, right? But when you get into it, when you get into those high stress environments and everything, and all the assessment techniques that you have to give, it doesn't become very simple, right? So one of those perfect example, right? You want to count respirations. Now, where's the difficulty that lies here when you get to them? Number one, how loud the environment is, right? And when you speak to anybody that responded to Pulse nightclubs, one of the biggest things that absolutely was one of the things that the responding officers remember was the number of cell phones that were continually were calling for the victims' families and everything. So you have a loud environment, you have dim lighted. So how easy is it going to be for you to actually count respirations on a victim and be able to hear, whether or not they're moving air and to those things, right? So number one, and also your respiration rate is through the roof, right? Your vital signs, your heart rate's pumping, you're getting in there, right? You're working in that high stress environment. You're getting to that over that 140 beat threshold where things don't, simple functions become difficult at this point, right? So, how accurate is that? So essentially, we didn't feel it was simple, number one, to the operator that was operating in a stressful environment. That's number one. And number two, we believe there was a lot of gaps. So let's take an example of that, right? So you have an individual using Start Triage that has a gunshot wound to their abdomen. They're able to walk. Their respiratory rates between 30 and 10, right? They have distal pulses. They're able to follow simple commands, and they're able to ambulate, right? That's a green tag patient with a gunshot wound to their abdomen. It doesn't fit in this type of environment, right? So that, that victim is going to begin to decompensate quickly, especially in that environment. I mean, and so we understood there was gaps involved. Start Triage is great. It's an excellent triage tool in its proper format and its environment and where it's useful. But within the warm zone, it's at the end of the day, we're looking for individuals that have survivable injuries that we can get to the hospital where they need surgery. All right. The other patients in between, those patients can be re-triaged on the outside and the appropriate resources. And again, look, we also had to take a look at the rest of the country and the rest of the world. Is New York City, we're fortunate as far as when it comes to resources, right? So, when we call for ambulances, we have an infinite amount of ambulances that are going to come our way, or not an infinite amount, but we're resource rich. You're in these rural areas and these areas that have where it's going to take, time for not only their EMS resources to get there, their law enforcement resources to get there, their fire department resources to get there. They really, the incident commanders really have to take a look at how their resources are utilized and what patients are extracted and when. So again, taking a look at that, we focused heavily on core body injuries and on the warm zone triage. Why? Because when active shooter care first came out, the focus was very heavily on the Stop the Bleed program. Stop the bleed, stop the bleed. Is that important? Yes, that is absolutely important. But the difference between the rescue task force and a tactical medic or a first responder or just a bystander is the fact is, for a rescue task force to be established, get a law enforcement element, and for them to be actually dispatched into or directed to go into a certain location, that's over 20 minutes. And you can throw whatever study you want to throw at me. Any individual is going to bleed to death within 2 to 4 minutes with uncontrolled hemorrhage. So depending on what vessel is severed and whether or not they have any kind of makeshift tourniquet or anything, rescue task force those really aren't our patients in that situation. Of course, we're going to assess them for that hemorrhage, but our focus is heavily on core body injuries, because you can either look at whatever studies like the Smith study that show that a lot of the survivable injuries were those core body injuries if they were extracted in a timely fashion.
So let's just delve into that actually, Greg, because I understand you've done a number of tests and indeed orchestrated it in practice in reality, but could you look at or indeed speak to the warm zone triage under stressful high fidelity training? How does it perform when you run this through a triage situation?
All right. So let's first talk about warm zone triage, and again, to the people listening, I'm going to say this to you where you're not going to be able to physically see or give you a graph or anything, and it's going to show you the simplicity in it, right? So number one, if you come up upon a victim, the first thing you need to do is assess whether or not they are conscious or unconscious. All right. Second thing we're going to assess is breathing, just like anything else. If they're not breathing, we're going to readjust their airway once. And if they're not breathing with that readjustment, we're going to move on, and we're going to categorize that individual as a black category, and they're going to be listed as dead. And the difference, what we changed to within the warm zone, is that we utilize a surgical marking pen, and we make the markings on the forehead. Along the lines. Why? Again, we tried to make this as simple as possible. If I'm handing off that patient, or another team is coming in to assess a victim that's laying on the floor, the first place anybody ever really looks is somebody's face. So if we make markings on the face, it'll be the first thing. So black category, we're gonna put a B on their forehead, and with the surgical marking pen, and that's categories. The next thing that we're looking for is the massive hemorrhage. So we're gonna do a quick body sweep, take a look, and address any mass hemorrhage. We're looking for the ability to follow simple commands. All right. If they can follow a simple command, we simply ask them, can you raise your hand or not? Or if they're not able to follow simple commands, we don't need to go any further. They're automatically red category. So we're going to write red right on the forehead. Now, why you ask why we write red? Because we found out while going through these evolutions and doing everything that under stress, people's R's look like B's. So, again, concern there. The second category within a red is any kind of major trauma in the core body, which our core is easily identified as the top of the head to the groin, front and back. Any major trauma in those areas, they're automatically a red category. Why? Is because simply tell me pre-hospitally, what are we able to really do for those patients other than buy them time? They need a surgeon. All right. The best thing we can do for those victims is extract them, get them to the hospital as quickly as possible, identify them. We're going to put a chest seal on if they have any kind of open chest wounds. We're going to provide a needle decompression if they're showing signs of a tension pneumothorax. But have I solved the problem? No. We bought them more time to get them to the hospital quicker. So again, those individuals would be categorized as a red category. And again, we'd write red on the forehead. Anybody else that doesn't fit in those categories, if they're able to follow simple commands, or if they have wounds outside the core, whether or not they can ambulate or not, they're considered what's called alive. And we're going to put an A on their forehead. Those victims are going to be extracted and then brought out to staging areas and re-triage with start triage on the outside, right? Because the main goal of any rescue task force is to extract red tags and bring them right to the hospital. So identifying red as quickly as possible. Now, again, under stress, I'm not counting any respirations, right? I'm not checking for any distal pulses. again, your hands are sweaty, you got gloves on, you're moving around to how many patients, whatever you have going on in there. How easy is it going to be for you to feel somebody's distal pulse, right? It's not. You know, it wasn't practical. If we want accuracy and we want speed, you have to make it simple for the operator, for the everyday operator. And we really focused in on that. And by doing so, simply visualizing where a wound is and whether or not they're able to follow simple commands will tell you whether or not they're red tag. And we, again, extract those victims as quickly as possible. So, and simply explain that over the podcast, I can guarantee if we took calls and we took questions, I guarantee over 90% of the people would get it correct, just because it's really that simple. If you have an injury in this location, you're this. If you're not breathing, you're this. And if you have an injury here, you're this. So, again, make it as simple as possible, and it improves it accuracy.
I absolutely agree with that, Greg. And I think fundamentally the tool has to enable the clinician, because the clinicians are treating patients, and the more complex you make it, the more it slows the scene down and it slows patient care down, to your point that you keep making. And I think I absolutely agree with that. And one thing you mentioned, which is really interesting, and the 10-second triage tool does the same. It removes these physiological markers. So it removes, like you say, counting respirations, counting for a pulse, which I actually don't think ever happened in the first place. I think it was a lot more intuitive than that when people do respond to major incidents. So, but formalizing that, removing these physiological markers, as in counting respirations, counting heart rate, far more intuitive, right? Injury to the thorax, yes or no? Mentating, speaking, yes or no? And then being a lot more intuitive about, because like you said, they might be walking, but if they've got a thorax penetrating injury and/or abdominal injury, they're not going to be walking for long. And actually, that should never be a green or a priority 3 patient. So you're right, just flipping the mindset, removing the physiological markers, I think is absolutely an enabling tool. Just to that point, as we move on, looking at red patients, Greg. So you mentioned a couple of critical interventions. One is, mass hemorrhage, arresting mass hemorrhage, use of tourniquets and other things. Another is maybe opening an airway up. How does the warm zone triage deal with red patients? What are some of the fundamental interventions you're looking at?
All right. So great. I like to discuss our assessment technique. So when we're going in, so we're operating together as a rescue task force. We go in, we see a victim on the ground. Again, the first thing that we're going to do is we're going to assess someone's airway. If they're not breathing, again, we open up that airway, because it could be positional, that that individual's not breathing and they just they're not conscious. They don't have the ability to open up that airway at that time or protect it. We're going to open up that airway if they begin breathing. Our next step is, again, let's make the thought process easy. Massive hemorrhage is the next thing that's going to kill somebody, right? So if they're not breathing, if you're not breathing, you can still have a pulse. So, at the end of the day, next thing we're going to move on to is we're going to check for massive hemorrhage. We're going to sweep those voids. If we identify one, we're going to apply a tourniquet high and tight, right? That's something that we focus heavily on within our training, because I know a lot of the training that you go through, we're building training scars. Why? Because we're not having the operator apply tourniquets the way they're supposed to, right? So that was some of the things that we found out very early on, is that, turning the tourniquet twice and telling somebody that it's good because that's the training model that they're going through. Under stress, you're going to revert back to that, and you may not really be able to. You're not controlling the bleeding, number one. And I don't think I've ever applied a tourniquet and I've only had to turn the windlass twice. To be honest with you, right? I mean, even with larger individuals that you discussed, that one tourniquet may not even be enough, and a lot of these things aren't addressed in those, and that's something that we train heavily on training. when we do our evolutions. So we're gonna stop that major bleeding. The next thing that we're gonna do is now we're gonna assess the thorax, right? We're gonna expose the chest, and we're gonna perform a blood rake. We took that from our military. Why? Because if you've ever seen somebody shot with a 5.56 223 round, the penetrating wound is about the size of a pencil. All right, and when you have a chest covered in blood, it's not a very easy wound to find. So we begin from the clavicle down to the pelvis. We rake each side, and once we find a hole, let's make it easy, right? We get a commercial chest seal. We peel and stick. We can discuss here all day whether or not you want to do vented chest seal or non-vented chest seal, whether or not we're using duct tape or whatever the case may be. The goal here is to more or less put either a vented chest seal or a non-vented chest seal over that hole, right? We want to decrease that airflow going in there. So, again, our next technique at this point now is we want to assess for a tension pneumothorax. And again, let's make things easy for the operator. You have an open wound and trouble breathing or tachypnea. With that, we're going to pop the chest in that situation. I mean, you're just not going to have the ability to sit there with a stethoscope and take a listen to the lung sounds. And again, we've learned over time that looking for tracheal deviation, that's such a late sign. You're not effectively managing anything. But what I will tell you is that we've moved to 2 sites for our decompression. We're going to do mid-clavicular or mid-axillary, either one or two. And on adult patients, we're hubbing the needle because, again, whatever studies that you're taking a look at, whether or not we were actually using those decompression needles deep enough. We weren't getting them deep enough to actually release that air in there. So again, those are focused, right? And then the next thing is extracting those red tags. So simple. Goal is extraction, identify life threats, get them triaged, and get them out. And that's, we want to make this as simple as possible. I don't know why everybody's trying to make this complicated and trying to create this perfect format. You know what the perfect format? Getting the patient to the hospital. That's the perfect format.
So, Greg, looking at because if I'm right in thinking, it does interlock with the modified start triage. So it's removal from the warm zone to a cold zone for like blast or ballistic injuries. But then there's an application of a modified start triage tool. Am I correct in saying that? And if so, how does that look?
Mm-hmm. So we had discussed earlier about those alive patients, right? So our red category patients, ideally, we'd like to see them removed from the warm zone to some type of triage transfer point. That's what we categorize it. Pass them off to cold zone personnel, and they go right to awaiting ambulances, right? So again, it's about getting the red out. Those alive patients, all right, they get brought out to the cold zone, and they get put and they are re-triaged with our modified start triage. Now, why it's called modified is because we utilize an orange tag. Why do we come up with an orange tag, right? We have our normal black, red, orange, yellow, and green. An orange tag is more or less anybody that has a tourniquet applied, okay, that is, compensating, that is able to follow simple commands that, fit the other categories, right? So they have the tourniquet applied, or they're suffering from some type of medical emergency secondary to the event. And how do we find that out? Is we had a steam pipe explosion in New York City, and we had an individual on scene that initially was categorized as a green tag that started to develop MI symptoms and eventually went into cardiac arrest because they essentially succumbed from a myocardial infarction. And so that was something that we saw that within a certain area that individuals were falling through the cracks just for the fact of, nobody, took into account the medical emergencies that people could be having, right? Again, everybody practice. And when we go through, a lot of our evolutions are done with military aged individuals in usually pretty good shape. let alone that if we had an active shooter at an actual, whatever type of environment that we're looking into, unfortunately, like supermarkets and everything, you're going to have individuals of all shapes and sizes and all different types of, medical conditions that they're on medicine for, blood thinners, diabetics, everything else that comes along with it. So individuals come in all shapes and sizes. So the assessment techniques are important at this point. So we bring them out to the cold zone and we categorize or re-triage them. Those are live patients, re-triage them with our modified start triage, and then our resources are pretty much dispersed through the, whatever categories they come out, in that situation. So we want to do the best we can for the individuals that we are bringing out and try and categorize them, as appropriate as possible in that situation. So, and it's something that everybody can transition to, and there's an easy transition from those individuals that you bring out.
So, Greg, there's a certain element of over triage in every tool, and a certain element of redundancy, just to ensure we're capturing like you said, the fringe survivors, which might need an extra little bit of care, or indeed just to make sure we're not missing patients. Is there any redundancy and/or element of over triage in Warm Zone triage, the triage tool? Has that been built into it, or how does it perform in practice from a sort of a sensitivity perspective?
Again, the simplicity is where, we get that accuracy, right? So, those are things. And, again, going through it, we had to have, when we developed the system, we had to have it something that people could relate to and they can identify with, right off the bat. So, there wasn't much of a change in regard to that. And let's be honest, majority of people, or majority of operators and practitioners, look at an individual and they their first sight, right? They determine somebody, oh, they look bad, they're red, so they're over triaging right away, depending on the situation, because they're looking at the color of their skin, whether or not they're right. One of the things that gets brought up, that there's two things I'm pretty much concerned of in an active shooter environment. One, the medical provider feels comfortable treating somebody that is injured, that needs their help, and where they can feel they can do something about it. And I'm going to give you an example of what I mean by that, right? So you take the Aurora, Colorado situation where you had an individual that opened fire in a movie theater. So as soon as the first responders arrived to the scene, you had essentially, you're going to be met by those walking wounded right off the bat. Those people that are able to extract themselves right away are you're going to be more or less, dealing with them as they extract themselves. And you have an individual that's shot in the arm, that's a through and through, right? And I'm a medical, provider. I feel comfortable with taking that victim and putting them in the back of my ambulance right off the bat, because look, I have somebody shot, I'm wrapping their arm. I want to, transport them off to the hospital. Not really seeing the 50,000 foot view of you're utilizing an ambulance for an individual that no matter what in this situation, whether we just wrapped them, they sat there for 2 hours, they're still going to be alive. And then, where we need that. So that's a big concern right now, right? Is how to, one, train medical providers to move past those victims and how to deal with them appropriately and where to put them through. And then, moving into that next phase of it, of training together and working with your law enforcement ally and get them to trust enough that you're able to be protected and that you'll be safe in that environment and getting in there. I think a lot of places around the world are still having some difficulties there in light. Everybody thinks that they have a job and a responsibility, and that's true. But the end goal of all this is to help individuals that didn't have a chance in the first place now to have a chance and get them out. So, the simplicity, equals accuracy for the majority of the part. And then on top of that, it's, being able to relate to it. So that's, like what you're saying about the redundancy.
You make an absolutely great point there, Greg, around a fundamental mindset shift, because like you said, on an ordinary day, we call it, I guess, business as usual, BAU. Business as usual is one patient, one ambulance, a couple of clinicians, an ambulance crew. And and you treat what you see in front of you. But in the hierarchy of need in a major incident or a mass shooter incidents, you have that mindset is absolutely flipped. And like you said, the through and through arm injury might not be your priority. And actually the heuristic or bias is that you err towards what you're comfortable with. But actually it's being able to step aside from that, see there is maybe a different hierarchy of need at play, and there's actually maybe more injured patients that might need your attention. And to your point, actually, Greg, I think the initial tool application is all structural, and so applying the structure means you don't necessarily treat that first patient you see in front of you. It's the structure, it's the reporting system, it's then the application of dynamic triage, which is a mindset shift from everyone's day-to-day practice. And I think, if being honest with you, I think every major incident which has occurred in the past, clinicians are faced with this fundamental challenge of shifting mindset from their 364 days. The 365th day, it's a complete mindset shift. Demand outstrips supply, and they have to really start to look at these structural components rather than treating the first patient they see in front of their face. To that point, Greg, I just wondered if it'd be really interesting to just examine how warm zone triage looks from a reporting perspective, because there is an element of tactical operations command on these scenes, both maybe at scene and remote from scene. How does warm zone triage sort of interface with this sort of tactical command? Is there sort of 5-minute SBAR sort of situation background assessment recommendation tools being relayed to a command station, or how does that look?
So, that's a great question, and that's another thing that is probably the most important thing to any aspect of these types of environments, right? Communication, right? It's the most important thing on any assignment, and it's the first thing to break down, and it's the least emphasized in training. So, tell me where that makes sense, right? So, that's something that, again, huge focus of ours. It's, having a hub together of more or less a unified command, a small structure of our tactical operations command, where our warm zone triage is simply relayed back to number of patients and the categories. So again, I don't know how to make this any clearer. Stop making things complicated, right? At the end of the day, what was our foundational goal? It's about getting a read out. Number two, how do we improve that? How do we make that as fast as possible? And we've really found that we make it as fast as possible, but making it as simple as possible. All right, listen, while I'm inside, I'm communicating to my location, to my tactical command of that I have this many patients and I have this many category. And then we break it down to black, red, and alive, right? So let's not overcomplicate this. Let's go into, evolve. But now that transition also. So we're a part as a rescue task force. We've already relayed to our tactical operations command that we're coming out with 5 red category patients. We're going to pass those off to personnel. We realized that we had to give some type of direction of the information that needs to be passed from one to the other. So we took a look at what, more or less was around the world. And we saw that a missed report that was used by the military is a good format, but it doesn't work for what we had. So we developed a lit report. So we felt the most important information that needs to be transitioned from one provider to another from their operation is level of consciousness, injury sustained, and the treatment that you provided. Let's stop making this complicated, because before, if I'm passing a patient off to you, I'm either really saying little to nothing, or I'm giving you a very convoluted patient assessment pace-off information that included the person's credit score. And that's pretty much what it came down to. So again, we focused in and we really tried to cut out the fat as much as possible. So, communication is really bare bones. while we're operating in a warm zone, and all that further information of any of the things that become complicated that could be all done in that cold zone operation, where those providers aren't under the stress of wearing any type of body armor or stress or getting patients and dragging them in and out in a timely fashion, or getting to a certain location. All that does is increase your heart rate. It puts a lot of stress on the provider, and it all depends on, let's be honest, how good a shape that individual is that's making their way there. If I'm going from room to room to room, doing a number of assessments over a long period of time, again, that's going to have an effect on the operator, right? And that's going to have an effect on, how accurate they are later on. If you're exhausted, we talked about that before. How accurate am I going to be on respiratory rate? How accurate am I going to be on counting or checking, distal pulses? These are things that we really had to take into account on an individual. Hey, listen, are they able to lift their hand? Yes, great. That means they're able to follow simple commands. Do they have major trauma from the top of the head to their groin, front and back? Yes, good. All right, let's get out. And again, that triage, it needs to be simple. You have time later on for those individuals that aren't critical. Those critical patients, at the end of the day, just need to get to the hospital as quickly as possible. They need to get onto a surgeon's table and identifying those.
Yeah, Greg, listen, I fundamentally believe in everything you're saying, actually, around the simplicity is absolutely key. And use of a simple tool, such as LIT, level of consciousness, interventions and or treatments, and just looking at keeping everything simple from a reporting perspective to an initial triage, because like you said, an initial triage might be quite different 5-10 minutes down the line, and they're going to need re-triaging anyway. So a complex tool would never work anyway, because actually things are so dynamic in that environment. Greg, as we come into land on the conversation, there's been some salient points you have made throughout this interview around keeping it simple. Could you maybe just notion towards a few take-home messages that listeners could sort of take away and or think about from the conversation?
Number one, communication is everything, right? On any type of these environments, the communication, with your law enforcement element and your rescue task force and the individuals that are there is huge, right? Two, train. It's all about training, developing that muscle memory, going into things, utilizing things that work for you and your agency, and going through. Focusing on that, make sure you identify those life threats. Make sure you do those interventions quickly and extraction. Again, you've heard me say it numerous times throughout this the podcast. It's all about getting the red out. I'm thankful for the fact now that we have these campaigns of Stop the Bleed campaign, which is 100% the way to go is to get those bystanders, get those individuals, trained to assist in these things, because it takes community in these types of situations. And, it's going to take time for your medical providers and your professionals and your law enforcement element to get there and begin to establish these things to get in there and deal with these victims. But it's about getting the red out. It's about simplicity. It's about not just the patient, but it's about the provider. Understand the amount of stress that they're under, and if we want them accurate, we have to make it simple. And that's the biggest points I can make to you is trying to get them out.
Listen, that's fantastic, and I fundamentally believe in that. I think it's a great place to land the conversation. I think, Greg, what we'll do in the show notes is we'll put links to some of the other fantastic interviews that you've given on Warm Zone Triage, just to give listeners a holistic perspective on Warm Zone Triage and some of the fantastic information you've given there as well, because it really is innovative and progressive. But listen, thank you for your time, Greg. I really do appreciate the last 45 minutes.
I appreciate it. Thank you very much for having me. And, things like this and getting people out there and talking to each other is the number one thing that we can do.
Thanks for listening to the episode. please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.